Hello, and welcome to the Psychological Disorders chapter of your general psychology course. Remember, in general psychology, we are only covering the basics, which means we only learn kind of the top layer of information. And also remember that this is just a walk through your textbook. It's not a full on out lecture. Be sure to read through your textbook or contact your instructor or professor if you have any questions about this material. So, psychological disorders. Psychological disorders. Psychopathology is the study of psychological disorders, including their symptoms, etiology, and treatments. Etiology meaning history and treatments. Psychological disorder is a condition characterized by abnormal thoughts, feelings, and behaviors. Psychologists work to distinguish psychological disorders from inner experiences and behaviors that are merely situational, idiosyncratic, or unconventional, excuse me. Behavioral disorders that are atypical to inner experiences, deviate from the norm, distressful to self or others, or are dysfunctional. So, rejection, a little dejected versus depression. So, feeling rejected by something doesn't equal what depression would be. Just because something is atypical or different doesn't mean it's a disorder. For example, red hair, 4% of the population is about the amount that have red hair, but it doesn't mean it's a disorder. Eccentric does not mean mentally ill. If someone is eccentric, it doesn't mean that they're mentally ill. So, for example, somebody who has collects, I don't know, rabbits or little bunny figurines that are completely covering their entire house, unless it's somehow inhibiting their functioning or causing distress, it may be eccentric to collect that many bunnies, but it's not a mental illness. So, your cultural expectations. So, eye contact in the United States and Europe, eye contact with others is typically signifies honesty and paying attention. Latin America, Latin American, Asian, and African cultures interpret direct eye contact as rude, confrontational, or potentially aggressive in some areas of those cultures. Eye contact with you could be considered appropriate and respectful or brazen and offensive, depending upon the culture that you're in. A hallucination. So, hallucinations are seeing or hearing things that are not physically present. Western societies, it's a violation of cultural expectations, whereas other cultures may view visions pertaining to future events. They may regard this as normal and positively valued. It is important, though, to recognize that cultural norms change over time. What might be considered typical in a society at one time may no longer be viewed this way later. Thomas Szasz in the 1950s and 60s challenged mental illness. He stated that quote, myth that justifies psychiatric intervention in socially disapproved behavior. Today, we recognize the extreme level of psychological suffering experienced by people with psychological disorders, the painful thoughts and feelings they experience, the disordered behavior they demonstrate, and the levels of distress and impairment they exhibit. This makes it very difficult to deny the reality of mental illness, but reading some Szasz material is really interesting because during that time, there was a huge push for absolutely any kind of misbehavior by children or erratic behavior by women was deemed as mental illness when in actuality it was not. It was not. So it's interesting to read up on some Szasz information, but we don't deny that there are psychological disorders that people suffer from. So harmful dysfunction, Jerome Wakefield coined the term harmful dysfunction as defined as mental disorder. Psychological processes honed by evolution, such as cognitive and learning, have important functions, such as enabling us to experience the world the way others do and engaging in rational thought, problem solving, and communication. Dysfunction occurs when internal mechanisms break down and can no longer perform its normal function. The dysfunction must be harmful and that it leads to negative consequences for the individual or others, as judged by the standards of the individual's cultures. The harm may include significant internal anguish, It's not going to work because there's a if you're not going to work because there's a cat and on the front steps in front of your apartment and you have a fear of cats, well, that's going to cause some serious dysfunction in your life. You're not going to be able to get to work. So you're going to need to get some help or intervention to be able to get out of your house. The American Psychiatric Association, APA, definition: there's a significant disturbance in thoughts, feelings, and behavior. A person must experience inner states and exhibit behaviors that are clearly disturbed, that is, unusual, but in a negative, self defeating way. The disturbances reflect biological, psychological, or developmental dysfunction. Disturbed patterns of inner experiences and behaviors should reflect some kind of flaw. The disturbance leads to significant distress or disability in one's life. The psychological disorder, if they cause a person considerable distress or greatly impair his or her ability to function as normal individual. The disturbances do not reflect expected or culturally approved responses to certain events. Disturbances in thoughts, feelings, and behaviors must be socially unacceptable, responsive to certain events that often happen in life. Diagnosis and classification of psychological disorders. Diagnosis: appropriately identified as labeling a set of defined symptoms. It's crucial because it enables a common language among professionals in the field. The Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, first edition was published in 1950, classified psychological disorders according to format developed by U.S. Army during World War II. DSM-5, the manual has changed over time. For example, homosexuality was removed from the manual in 1973, and internet gaming is currently under review to be added as a formal disorder to the next generation of the DSM. The International Classification of Disease was published by the World Health Organization and was developed in Europe shortly after World War II. It was revised several times. Categories of psychological disorders are similar in the ICD and the DSM, but the DSM includes more explicit disorder criteria. Worldwide, the ICD is used more for clinical diagnosis and the DSM is used more for research. The compassionate view of psychological disorders. Remember that psychological disorders represent extremes of inner experience and behavior. If while reading about these disorders, you feel that these descriptions begin to personally characterize you, don't worry. This moment of enlightenment probably means nothing more than you are normal. Each of us experience episodes of sadness, anxiety, and preoccupation with certain thoughts, times when we do not feel quite like ourselves. Understanding that people with psychological disorders are far more than just the embodiments of their disorders is also important. Statements like he's schizophrenic and she's bipolar, or he's such and such, or they're such and such, kind of takes away from the identity of the individual, and it's identifying them by their disorder. So here's a video you can watch. It's also in your textbook, of an amazing poem that was written about identifying an individuals as their disorder as opposed to themselves. So you can check that out. It's in your text, or it's in your overview or your textbook chapter for this chapter. Supernatural perspective. This is attributed to a force beyond scientific understanding. Mental illness is the result of demonic, something demonic taking over the person. We had trephinning or trephination, trephiny, where they would drill a little hole into the individual's head to release spirits. Also thought to, people thought that they were also going in to do surgery to remove stones of madness from individuals' brains. There's a very famous painting, 15th century painting by Hieronymus Bosch, with a practitioner using a tool to extract this supposed stone of madness. The biological perspective tells us that psychological disorders are linked to genetic factors. Neural imaging technology in recent decades has revealed how abnormalities in the brain structure and function might also directly be involved in many disorders, and advances in our understanding of neurotransmitters and hormones have yielded insights into the possible connections. The biological perspective is currently thriving in the study of psychological disorders. The diathesis stress model. The diathesis stress model states that it integrates the biological and the psychosocial factors to predict the likelihood of disorders, suggests that people with underlying predispositions for a disorder, the diathesis, are more likely than others to develop a disorder when faced with adverse environments or psychological events. Key assumption of the diathesis stress model is that both factors, diathesis and stress, are necessary for the development of the disorder. Different models explore the relationship between the two factors. The levels of stress needed to produce the disorder is inversely proportionate to the level of diathesis. So looking into the different categories of disorders. So anxiety involves apprehension, avoidance, cautiousness regarding a potential threat, perceived potential threat, danger, or negative event. That's the motivator to the anxiety. Anxiety disorders are excessive and persistent fear and anxiety related to disturbances in behavior. It's very common. Between 25 and 30% of US population meets the criteria, more common in women than men. Most frequently occurring class of mental disorders, and it's often comorbid, meaning there's more anxiety is often, there's other disorders with anxiety. So anxiety disorders, specific phobias, these are experiences excessive distress and persistent fear of anxiety about one specific object or situation, and it must be disruptive to daily living. It's fairly common. 12.5% of the US population report having a specific phobia. Agoraphobia, is translated fear of marketplace, is an intense fear or anxiety and avoiding of situations in which it might be difficult to escape or receive help if one experiences a panic attack. The acquisition of phobias can be through classical conditioning, if you remember Pavlov with classical conditioning, modeling or verbal transmission. Evolution of psychologists argue that we are kind of predisposed, evolutionary psychologists, we're kind of predisposed with some of these phobias, like spiders and snakes and thunder, for example, because, well, I mean, it makes sense. Let's stay away from spiders and snakes. And, well, if it's thundering, let's get out of the potential storm. Social anxiety disorder is an extreme persistent fear of or anxiety and avoidance of social situations in which the person could potentially be evaluated negatively by others. 12% of Americans across a lifetime have experienced social anxiety. Fear, one may act foolish, show anxiety, or say or do something wrong. You have safety behaviors such as mental or behavioral acts that can reduce anxiety in social situations. So anxiety disorder, panic disorder. This is reoccurrent and unexpected panic attacks, along with at least 1 month of persistent concern about additional panic attacks, worry over consequences that the attacks are self-defeating, changes in behaviors related to the attacks. So that's where a lot of the anxiety comes from with panic disorder, is the anxiety that there will be another panic attack. Comorbidity anxiety disorders are often you see with major depressive disorder. Panic attack is a period of extreme fear or discomfort that develops abruptly and reaches a peak within about 10 minutes. Can be expected in response to an external trigger or unexpected. There can be no trigger. Panic attacks alone are not a disorder. Some of the physical manifestations of panic attack are shown. People may also experience sweating, trembling, feeling of faintness, fear of loss of control, among other symptoms. So your autonomic nervous system is kicking in pretty hard when a panic disorder starts. Causes. So genetics, we see a 43% heritability. Individuals that have anxiety disorders, panic disorder causes, or have anxiety disorders, about 43% inheritability. Neurobiological theories, the locus coeruleus in the brainstem is possibly involved. Major source of norepinephrine, so your fight or flight's being triggered. Activation is associated with anxiety and fear and produces panic-like symptoms in non-human primates. Conditioning theory, panic attacks are classically conditioned, and So essentially, you've been conditioned for something to trigger the anxiety. Cognitive theories: individuals with panic disorders are prone to interpret ordinary bodily sensations as catastrophic, setting the stage kind of for the panic attack. In some patients, reducing catastrophic cognitions about situations has been as effective as medication in reducing panic attacks. Anxiety disorders, generalized anxiety disorder, a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension. So GAD, generalized anxiety disorder. The diffuse worrying and apprehension is not part of any other disorder. Affects about 5.7% of US population during their lifetime. Females 2 times as likely as males to experience the disorder. It's quite often comorbid with mood disorders and other anxiety disorders, but it's kind of a pervasive worry about, oh, something's going to happen, something's going on. Obsessive compulsive related disorders. So obsessive compulsive disorder involves thoughts and urges that are intrusive and unwanted. You have your obsessions and or need to engage in repetitive behaviors or mental acts, compulsions to be able to settle the anxiety and the obsession. So the obsession is persistent, unintentional, unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. Common obsessions: concerns about germs, doubts, order and symmetry, or aggressive or lustful urges. Compulsions: these are repetitive or ritual acts typically carried out primarily to minimize the distress that the obsession is triggering or to reduce the likelihood of a feared event. They're not performed out of pleasure. It's performed to be able to reduce the anxiety. The person usually knows these obsessions and compulsions are irrational, but suppressing them is very difficult, experienced by approximately 2.3% of the US population in their lifetime. Obsessive compulsive related disorders, obsessive compulsive disorders. Obsessions are characterized by persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. Compulsions are repetitive and ritual acts that are typically carried out primarily to minimize the distress. So let's say, for example, someone has the obsession of my house is going to be robbed, my house is going to be robbed, my house is going to be robbed. But if you flip your key 6 times when you leave your house and then kick your door frame twice, you can kind of calm that obsessive thought. So you get into a ritual act. Well, when these ritual acts start to become intrusive in your life, so for example, hand washing because of obsession of germs to the point where your hands are cracked and bleeding, then you're getting into, now it's causing dysfunction. Body dysmorphic disorder involves a preoccupation with a perceived flaw in an individual's physical characteristics that is either non-existent or barely noticeable. So, for example, somebody may believe that their ears are not in the same at the same height, so they'll go to get surgery to have that adjusted. Causes person to engage in repetitive and ritualistic behaviors and mental acts, constantly looking in the mirror, trying to often hide the body part, comparing with others. They may get cosmetic surgery. By the third cosmetic surgery, if you go in for a third cosmetic surgery, let's say on your nose, because you think something's wrong with it, they're going to do a psych eval to make sure that there's no body dysmorphic disorder with regards to you wanting these procedures done. So hoarding disorder involves great difficulty in discarding possessions, all possessions, not just I have a hard time throwing out my grandmother's paintings, of which I have probably about 60. Things that they'll even with hoarding, it's excessive to the point of even trash. They think it might be useful later, or I can use this wrapping paper later. I can use this paper towel if I let it dry. Excessive clutter and individual taking up their necessary living space. The diagnosed, if the hoarder is not a symptom of another disorder. So if you have other things going on, often if you work with the individual who is in a hoarding situation, if you work with them on other levels, the hoarding behavior is because of the other symptoms, the other issues. So you can't just go in and be like, oh, they just don't want to throw stuff away. We'll just clean up their house, because it's not, it's just going to go right back to another hoarding situation. Um, other related what obsessive compulsive related disorder causes: genetics, 5 times more frequent in first degree relatives of people with OCD. Identical twins, 5% concordance rate. Fraternal twins, 22% concordance rate. Genes involved regulate the function of serotonin, dopamine, and glutamate. Conditioning theories: symptoms of OCD are learned responses resulting from both classical and operant conditioning. You have your neutral stimulus, your unconditional stimulus, and then you're leading to the anxiety disorder. Once the association has been acquired, encounters with the neutral stimulus trigger anxiety and obsessive thoughts. Anxiety and obsessive thoughts continue until the strategy is identified to relieve it. Relief then may be ritualistic behavior, or mental activity that reduces this anxiety, and the compulsive act becomes then negatively reinforced. You do this act, it reduces the behavior, so it's reinforcing you, or it reduces your feeling of anxiety, so it's reinforcing that it's increasing you to do that behavior. If washing my hands makes me go, ah, good, now I'm not germy, I'm going to continue washing my hands over and over and over again to get rid of that obsessive thought or that anxiety. OCD circuits, several interconnected regions that influence perceived emotional value of stimuli and selection of behavior and cognitive responses. Abnormalities in these areas may produce symptoms of OCD. Orbital frontal cortex, this involved in learning and decision making, becomes hyperactive in people with OCD when provoked with tasks such as looking at photos of a toilet or pictures hanging crooked on the wall. PTSD, post-traumatic stress disorder that occurs in some individuals after extremely stressful or traumatic events: combat, natural disaster, sexual assault, auto accident. Symptoms: intrusive and distressing memories of the events, flashbacks, states in which the individual relives or experiences the event, avoidance of stimuli in connection to the event, persistently negative emotional states, feelings of detachment from others, irritability, proneness towards outbursts, or exaggerated startle response. Cognitive theories: 2 key processes in development and maintaining of PTSD: disturbance in memory for the event. Poorly encoded memories of trauma become fragmented, disorganized, lacking detail. Individual cannot remember event in a way that gives meaning and context, may become haunted by these fragments, involuntarily triggered by associated stimuli associated with the event. Negative appraisals of trauma and its aftermath: I deserve this. I deserve to be raped because I'm stupid. This may lead to dysfunctional behavior patterns that maintain the symptoms and prevent change in the problematic appraisal. The conditioning theories: traumatic events, unconditioned stimulus, extreme fear, and anxiety, unconditioned response. Cognitive, emotional, and physiological and environmental cues are now associated with this trauma event. So now your traumatic reminders create that extreme fear and anxiety. Mood disorders, characterized by massive disruptions in mood and emotions that can cause a distorted outlook on life and impaired ability to function. Depressive disorder, depression, intense and persistent sadness is the main feature. Bipolar and related disorders: mania is extreme elation and agitation is the main feature. A manic episode is a distinct period of abnormality and persistent, elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting at least 1 week. Diagnostic criteria for mood disorders: depressed mood most of the day, nearly every day, loss of interest in pleasure and usual activities, loss of desire to find pleasure in things, which is an anhedonia, at least 5 symptoms for 2 weeks, for a 2-week period, Symptoms cause significant distress or impair normal functioning and are not caused by substances or a medical condition. Major depressive disorder is episodic. Symptoms are usually present at their full magnitude for a certain period of time, then gradually diminish and then return again. Symptoms may be a certain period of time and then they return. Symptoms: weight loss or weight gain, increase or decreased appetite, difficulty falling asleep or too much sleep, psychomotor agitation or psychomotor retardation, slowing down of the psychomotor, fatigue, loss of energy, feeling of worthlessness or guilt, difficulty in concentrating, indecisiveness, suicidal ideation, thoughts of death, thinking about planning suicide or suicide attempts. Prevalence of mood disorders. About prevalence 6.6% of the US population each year and 16% of the US population in their lifetime, more commonly among women. The comorbidity, often you will see depressive disorders with and mood disorders with anxiety and sometimes substance abuse disorders, but quite often anxiety will also be diagnosed with depressive disorders. Risk factors: unemployment, low income, living in urban areas, being separated, divorced, or widowed. Yeah. So subtypes of depression. Seasonal pattern. It used to be known as seasonal affective disorder, but now it's seasonal pattern, applied to situations in which a person experiences a symptom of major depressive disorder only during a particular time of year. Peripartum onset. This is postpartum depression, major depression during pregnancy or 4 weeks following the birth. Persistent depressive disorder, dysthymia. This is mood disorder, depressed moods most of the day, nearly every day for at least 2 years, as well as at least 2 of the other symptoms of major depression. Chronically sad, but you don't meet all the criteria for major depression. Mood disorders, bipolar disorder. This involves a state that fluctuates between depression and mania. Now, it doesn't fluctuate quickly. It's not that this morning I'm feeling elated and then the next day I'm feeling depressed. Symptoms of mania are excessive talkativeness, excessive irritability, exhibit fight or flight ideas, talking loudly or rapidly, abruptly switching from one topic to another, easily distracted, exhibit grandiosity, flattened but unjustified self-esteem and self-confidence, show little need for sleep, take on several tasks at once, engage in reckless behavior. The prevalence: onset is typically before age 25, affects 1 out of 100 people in the US in their lifetime. 36% of these individuals attempt suicide. The comorbidity, anxiety disorders and substance disorders. So, biological basis: neurotransmitters. Mood disorders often involve imbalances in neurotransmitters, particularly serotonin and norepinephrine. These neurotransmitters are involved in bodily functions that are disrupted in mood disorders. Many medications designed to treat mood disorders work by altering neurotransmitter activity in the neural synapse. Medications for depression usually increase serotonin and norepinephrine activity. Medications for bipolar, such as lithium, which blocks norepinephrine activity of the synapse. Brain anatomy. Depression. The amygdala is important in assessing the emotional significance of stimuli and experiencing emotions. Depressed individuals react to negative emotional stimuli, such as sad faces, with greater amygdala activation than do non-depressed individuals. Also more prone to react emotionally to negative stimuli. Prefrontal cortex, important in regulating and controlling emotions. We see a decrease in activity in depressed individuals, which may inhibit its ability to override negative emotions. Greater difficulty controlling emotional reactions. Individuals suffering from depression also have a lower threshold for pain. Major diathesis stress model, major depressive disorder. Stressful life events often precede the onset of the depressive episode. However, not everyone who experiences stressful life events develops depression, suggesting a predisposition or vulnerability factor could be involved. So genetic vulnerability, we see an alteration in the 5-HTT-LPR gene, which regulates serotonin. One or two short alleles plus stressful life events is increasingly likely to have a depressive episode. A study on gene environment interaction in people experiencing chronic depression in adulthood suggests a much higher incidence of individuals with short version of the gene in combination with childhood maltreatment. So having a short version of the gene and having childhood maltreatment, significantly more likelihood of suffering from depression. And again, this is just general psychology, so it's not getting very in depth into these topics. Take abnormal psychology if you want to really get into some of this. All right, so cognitive theories of depression. Cognitive theory suggests that depression is triggered by negative thoughts, interpretations, self-evaluations, and expectations. So the diathesis stress model, you have your cognitive vulnerability, your stressful event, and then you have your phonological loop. You have your ideas, your thoughts of the event. Theorize that depression-prone people process mental predispositions to think about most things in a negative way. So depressive schema contains themes of loss, failure, rejection, worthlessness, inadequacy, may develop in childhood in response to adversive experiences, dormant until activated by stressful or negative events, prompt dysfunctional and pessimistic thought about the world and the future, maintained by cognitive bias, which lead us to focus on negative aspects of experiences, interpret things negatively and block positive memories, supported by research, lead to the development of cognitive behavioral therapies. Led to the development. Cognitive theories of depression, specific negative thinking style, sense of hopelessness, and then depression. Negative thinking refers to the tendency to perceive negative life events as having a stable, meaning it's never going to change, and global, meaning it's going to affect my whole life. Creates a view that life events will happen, negative implications for a person's future and self-worth, increasing the likelihood of feeling hopeless. Hopelessness is an expectation that unpleasant outcomes will occur or desired outcomes will not occur. And there is nothing one can do to prevent such outcomes, seen as the primary cause of the depression. Rumination is you have a distressed mood, you ruminate on that, and it increases the risk of the duration of the mood. Rumination is repetitive and passive focus on the fact that one is depressed and dwelling on the depressive symptoms themselves, rather than distracting oneself from the symptom or attempting to address them in an active problem-solving manner. And with major depression, sometimes it's very hard for the individual to be able to get past the not having a desire to do anything. So to say to somebody, oh, well, if you just stop thinking about it and do something fun, you'll be fine. It's way more complex than that. But again, this is general psychology, so we're just learning the basics. Suicide. Statistically, 90% of those who complete suicides have had a diagnosis of at least one mental health disorder. 10% of leading causes of death for all ages in 2010, an average of 105 a day. 4 times higher among males, 70% of all suicides than females. Males most commonly use firearms, females most commonly use poison. Risk factors: substance abuse problems, 10 times greater in individuals with alcohol dependency, previous suicide attempts, access to lethal means, precursors: withdrawal from society, feeling like a burden, engaging in reckless and risk-taking behaviors, sense of entrapment, feeling unable to escape feelings of external circumstances, cyberbullying, suicide of a family member, and serotonin dysfunction. And at the top, you will see the suicide prevention lifeline. There are people on the other end of that phone to help you or a friend or someone you love if they are having thoughts of suicide, and it should always be taken seriously. All right, so getting into schizophrenia. Again, this is general psychology. These disorders are so much more complex than what I have just kind of gone over that your textbook is giving you. Okay. It goes way deeper than this, but let's touch on some of schizophrenia. Schizophrenia is a psychotic disorder in which you have hallucinations and delusions. Hallucinations are perceptual experience that occurs in the absence of an actual external stimuli. So hearing, seeing, touching, tasting, feelings, smelling something that isn't actually there. Delusions are beliefs that are contrary to reality. Paranoid delusions, belief that one is agency is plotting against them. Grandiose belief that one holds special powers, unique knowledge, or extremely important. Uh, Somatic delusions believe that something highly abnormal is happening to one's body through thought withdrawal or insertion delusions. Disorganized thinking, this disjointed and incoherent thought processes, disorganized or abnormal motor behavior, unusual movements, catatonic behavior, which is a decrease or a satiation of activity or reactivity to the environment. Negative symptoms, decrease in and absences in certain behaviors, emotions, drives. Avolition, this is a lack of motivation to engage in self initiated meaningful activity. Alogia, this is reduced speech output. My brain just did not want to read that. Asociality, this is a withdrawal from society. And anhedonia, the inability to experience pleasure. So positive symptoms are things that are added to the individual, such as hallucinations. Not saying they're good symptoms. It's saying it's positive, it's added. It shouldn't be there, but it is. Whereas negative symptoms are things that should be there. We should want to be around others. We should want to experience pleasure, but those are negative symptoms, things that are taken away. Affects about 1% of the population's genetics. Risk is 6 times greater if one parent has schizophrenia, even if adopted. Neurotransmitters, dopamine hypothesis, and overabundance of dopamine, or too many dopamine receptors are responsible for the onset and maintenance of schizophrenia. It's a theory. Drugs that increase dopamine levels can produce schizophrenic-like symptoms. Medications and that block dopamine help reduce the symptoms. High levels of dopamine in the limbic system lead to hallucinations and delusions, and low levels of dopamine in the prefrontal cortex are the negative symptoms. Brain anatomy, we see enlarged ventricles, reduced gray matter in the frontal lobes, and many show less frontal lobe activity when performing cognitive tasks. During pregnancy, obstetric complications during birth, mothers exposed to influenza during the first trimester, or mother's emotional stress. So, and again, this is just general psychology. So it's very limited what you're learning about the disorder. There's a little bit more in your textbook about it, but that's kind of about all you get in general. Dissociative disorders, characterized by an individual becoming split off or split from themselves as a core sense of self, memory, and identity become disturbed. Dissociative amnesia, this is the inability to recall important personal information, usually follows a stressful or traumatic experience. Dissociative fugue, individual suddenly wanders away from home, experience confusion about their identity, and in some cases may even adopt a new identity, not knowing where they've come from, where they've been. Depersonalization, derealization disorder. This is characterized by recurrent episodes of depersonalization, feeling like they're not oneself, or derealization, feeling kind of like they're not part of reality. Depersonalization is feelings of unreality or detachment from or unfamiliar with oneself. Derealization, sense of unreality or detachment or unfamiliarity with the world, be it individuals, inanimate objects, or all surroundings. Now, dissociative identity disorder, formerly known as multiple personality disorder, individual exhibits 2 or more separate personalities or identity, involves memory gaps for time during which other identity is in charge. Individuals tend to report a history of childhood trauma. Adoption of multiple personalities may serve as psychological importance for coping mechanism for threat or danger. This is highly malingered, meaning this is the majority of individuals who it is a very, very extremely rare disorder. And even Sybil, Three Faces of Eve, came out and said, I know I didn't actually have the disorder. So it's to say, does it exist? Yes. but unfortunately, it's one that's been quite manipulated by Hollywood as and done a very poor job of it. So someone who's genuinely suffering from this disorder, I mean, they're having some serious issues functioning, whereas some people, they're just unfortunately malingering, they're faking the disorder. So personality disorders, characterized by a pervasive and inflexible personality style that differs markedly from expectations of the individual's culture and causes distress or impairment, begins in adolescence or early adulthood. The prevalence, slightly over 9% of the US population, suffers from personality disorders. Avoidant and schizoid personality disorders are most frequent. Antisocial and borderline personality disorders are most problematic. These are the personality disorder clusters. Everyone fits within one of these clusters. It does not mean you're diagnosable with personality disorder. This is where the disorder goes kind of above and way beyond being functional. So I may be a little bit histrionic in that I want people to notice me. I want to be the center of attention, but I know when to kind of back down, and I'm not going to be upset if I'm not. Okay. So someone may be a little bit more paranoid than someone else, like, what's going on around me? People are watching me, or I think somebody's been scoping my house, but they're not diagnosable with a personality disorder. It doesn't get to the point where they are inhibiting their daily functioning because of the way that their personality is laid out. This is extreme, in which they're having a hard time functioning. Borderline personality disorder, characterized by instability in interpersonal relationships, self-image, and mood, as well as marked impulsivity. Symptoms: cannot tolerate the thought of being alone, will make frantic efforts to avoid abandonment or separation. Relationships are intense and unstable. Unstable view of self might suddenly display a shift in personal attitudes, interests, career plans, and choice of friends. May be highly impulsive and may engage in reckless and self-destructive behaviors. May sometimes show intense and inappropriate anger. Can be moody, sarcastic, bitter, and verbally abusive. Affects about 1.4% of the US population. Comorbidity, sometimes with anxiety, mood, and substance use. Cause: core personality traits such as impulsivity and emotional instability show a high degree of heritability. Many individuals report childhood abuse as well. There is treatment for borderline personality disorder. Personality disorders are a little different than disorders. So if you have somebody that has obsessive compulsive disorder, they know they have the disorder. They know it's disruptive to their lives. They don't want to have the disorder. Whereas obsessive compulsive personality, that individual, they're not bothered by their disorder. It's not something they necessarily recognize as being a problem unless others recognize it as a problem. And then that's when they're seeking treatment. And there's very little treatment for personality disorders, the majority of the personality disorders, but we do see that dialectic behavioral therapy, DBT therapy, does help with borderline personality disorder. All right, antisocial personality disorder, characterized by lack of regard for others' feelings and rights and willingness to inhibit on those, willingness to infringe on those. Symptoms: repeatedly performing illegal acts, lying or conning others, impulsivity and recklessness, irritability and aggressiveness, failure to act in responsible ways, lack of remorse, over infatuation with oneself, superficial charm, lack of ability to empathize. Diagnosis requires individuals to be at least 18, observed in about 3.6% of the population, and it's more common in males. All right, so disorders in childhood. Neurodevelopmental disorders involved developmental problems in personal, social, academic, and intellectual functioning. ADHD is a pattern of inattention or hyperactivity and impulsive behavior that interferes with normal functioning. Prevalence occurs in about 5% of children. Boys are 3 times more likely to have ADHD than girls. Life problems: low education, attainment, low socioeconomic status, unemployment, low wages, substance abuse problems, and relationship problems. And again, this is just general psychology. So if you want to know more, you got to go a little deeper than general psych. Inattention: this is difficulty to sustain attention, failure to follow instructions, disorganized. lack of attention to detail, easily distracted, and forgetful. Hyperactivity, this is excessive movement, interrupting and intruding on others, blurting out responsiveness before questions have been completed, and difficulty waiting one's turn. Genetics, inattention, about 71% heritability, inactivity, about 73% heritability. The neurotransmitters dopamine, genes involved in thought to include at least two that are important in regulation of dopamine. Individuals with ADHD show less dopamine activity in the brain regions, especially those associated with motivation and reward. Medications have stimulant qualities and elevate dopamine activity. The brain anatomy study shows that smaller frontal lobe volume and less activation when performing mental tasks. Frontal lobe inhibits behavior and may explain hyperactivity, uncontrolled behavior of ADHD. So, autism spectrum disorder. Autism is characterized by an inability to form close emotional ties with others, speech, language abnormalities, repetitive behaviors, and an intolerance of minor changes in environment and normal routines. Autism spectrum disorder is probably one of the most misunderstood of the neurodevelopmental disorders. And it's changing consistently how we define autism. Symptoms: deficits in social interaction, do not make eye contact, turn head away when spoken to. Deficits in communication, one-word responses, difficulty maintaining conversation, echoed speech, and problems using understanding verbal cues. Repetitive patterns of behaviors or interest. Prevalence: affects approximately 1 in 88 children in the US, 5 times more common in boys. Causes: genetics, identical twins, 60 to 90% concordance rate. Fraternal twins, 5 to 10%. Genes involved are those important in the functioning of synapse circuits and facilitate communication between different areas of the brain. Environment, factors that contribute to new mutations, such as pollutants in the environment. So, child vaccine and autism spectrum disorder. Child vaccines in the late 1990s, a medical journal claimed autism triggered by the MMR. It was retracted, however, but the effects were long lasting in the attitudes and beliefs. So, please investigate. This video cannot be shown, so I don't have it set to play while I'm doing a video recording, but please check it out. I mean, I know there's still a large community that pushes autism and vaccinations. However, there's been longitudinal studies done, and even the National Organization of Individuals with Autism, it says that there's no claims that this vaccinations caused autism. All right. So again, general psychology. This is just the basics. So I hope you enjoyed going over your textbook, and remember to talk to your instructor or professor if you have any further questions. Have a great day. Thanks.